The answer you have in your head right now is probably wrong. You've heard the horror stories, casts, crutches, months off your feet. Maybe your doctor told you. Maybe someone you know lived through it years ago. So when you saw walk the same day, you didn't believe it. I get it. But what if that version of bunion surgery you're afraid of doesn't actually exist anymore? I've done this procedure more times than I can count. I've watched patients walk into my office braced for the worst and walk out the same day. I've also seen patients who waited 10 years because someone told them bunion surgery was brutal, told them by a doctor still using techniques from 30 years ago that most of us don't even touch anymore. We're going to cover what actually happens during and after modern bunion surgery, why the old recovery model made things worse instead of better, how to know if you're a candidate for this approach, and what questions to bring to your next conversation with a surgeon. Let's get into it. Most people picture bunion surgery recovery like this: a big clunky boot or cast, crutches, strict orders not to put any weight on the foot, and weeks of that, followed by more weeks of limited activity, 6 to 12 weeks before you're doing anything close to normal. That picture exists because that's what bunion surgery used to look like. That model wasn't designed to torture patients. It was the standard because the techniques available at the time demanded it. Large incision, major soft tissue disruption, bone cuts that needed time and immobility to stabilize. When you operate that way, you can't put any weight on the foot immediately. The biology of healing wouldn't allow it. So protocols built around that reality became the default. The problem? The techniques changed, and the protocols in most practice didn't. A huge chunk of surgeons doing bunion surgery today are still using surgical approaches and recovery plans that were current 20, maybe 30 years ago. Patients have no way of knowing this. When your primary care doctor tells you bunion surgery is brutal and the recovery takes months, they're almost certainly describing what they learned in medical school or saw years ago. They're not describing what's possible now. Patients are making life decisions based on outdated information. They're choosing to stay in pain. They're changing their shoes, modifying their lives, managing instead of fixing, because the version of surgery in their head doesn't exist anymore, at least not in the hands of surgeons using modern techniques. Minimal invasive techniques change the entire game. Most of what I do for bunions use small poke hole incisions. Sometimes so small stitches aren't even required. That same work used to demand long incisions and major structural disruptions, now happening through openings that heal fast and leave the surrounding tissues mostly intact. That's not a cosmetic difference, that's a mechanical difference that directly changes what the foot can handle on day one. In my practice, most patients walk on the day of their surgery, not hobbling, not on a walker, walk with the right footwear and clear protocols. Early weight bearing isn't just allowed, it's part of the plan, because active recovery, where the tissue is asked to do something from the beginning, produces better outcomes than immobility. The foot heals faster. The muscle atrophy that comes from weeks in a cast doesn't pile up, and the road back to full activity is shorter. I've had patients who've put this off for 10 years. They expected to schedule surgery months out, arranging for extended time off work and spending weeks on the couch, and then they had the procedure and they're walking out. Not every patient's outcome is identical. Bone structures, severity of deformities, specific corrections all need to affect the plan. But immediate and near immediate weight bearing is the baseline expectation of my practice, not the exception. If same-day walking is expected outcome, the entire calculus around the surgery changes. The conversation shifts from, can I afford 3 months off my feet, to what do the next 2 weeks actually look like? Return to activity, real activity, not just shuffling around the house, can happen as early as 10 days out. That's not what most patients have been told. But the technique is only part of the story. The philosophy behind recovery matters just as much. And there's where the most outdated thinking lives. The logic behind casting and crutching after surgery seems solid on the surface. Protect the surgical site, keep weight off it, give it time to heal without interference. And that was the model for decades. And it came from a reasonable instinct. Don't disturb what you just fixed. It spread because it was the safest thing a surgeon could recommend when the surgical technique left the foot in a fragile state. If you make a large incision, disrupt major tissues, and left the foot structurally stressed, immobility was genuinely necessary. The recovery protocol was designed to protect the outcome of a procedure that required it. The flaw is what immobilization costs you over 6 to 8 weeks. When a limb is immobilized, muscles atrophy, circulation slows down, connective tissues tighten, By the time the cast comes off, the patient isn't just recovering from surgery, they're actually recovering from the effects of prolonged inactivity layered on top of the surgery. The road to full function is longer than it needed to be, and the journey is harder. Immobilization, sold as protection, is often the main reason recovery takes as long as it does. Patients aren't told this. They follow the protocols because they trust it, because it was given to them by someone with authority, and then they spend months working back to the baseline and assuming that's just what bunion surgery is. Think about hip surgery. 15 years ago, hip replacement meant an extended hospital stay, weeks of restricted activity, and a long rehab time. The assumption was the joint needed time and protection before it could bear load. We know now that assumption was wrong. Modern hip replacement is done the same day. Patients walk immediately, and outcomes are better because the tissue heals more effectively when it's asked to function from the start. Active recovery isn't a shortcut, it's a superior model. Early weight bearing and early range of motion after bunion surgery, when the technique supports it, prevents the atrophy cycle. The foot is moving, the muscles are being used, circulation is supporting the healing tissue. The recovery is happening in a functional context, not a static one. That's why return to activity in my practice is measured in days and weeks, not months. This isn't some novel philosophy. Active recovery is the modern standard in orthopedic and podiatric surgery wherever the techniques have kept pace. The outcome data supports it, and the patient's experience reflects it. The patient who comes through my practice aren't toughing it out through some unusually difficult protocols. They're following a recovery model designed for the way the surgery was actually done. When you understand that immobility is a relic of old techniques, not an inherent requirement of bunion surgery, you stopped accepting it as a given, and you start asking whether the surgeon you're talking to operates in a way that makes early weight bearing possible. That's the right question to ask, which leads directly to the next question. How do you know if you're a candidate for this approach? If this is changing how you think about what bunion surgery actually looks like, subscribe so you don't miss what's coming next. We're covering the full picture of what modern foot and ankle care looks like, and most of this information patients aren't getting from their regular doctors. Most patients who come to me have been carrying a bunion diagnosis for a long time. Some were told to wait and see. Some were told to manage it conservatively forever. Some were told surgery was an option, but made it sound like a last resort. And somewhere in all of that, they formed a belief about whether surgery was right for them. The patient who benefits most from modern bunion surgery share a few things in common. They have a bunion that's affecting their daily life, their shoe choices, their activity level, the amount of discomfort they're managing on a regular basis. They've tried conservative option and got partial relief at best, and they've been holding off on the surgery because of what they expected it to cost them in time and pain. Ask yourself these. Are you buying shoes based on what your foot can actually tolerate rather than what you actually want to wear? Is the pain affecting how much you walk, exercise, or stand on any given day? Have you been told to just live with it or that surgery isn't worth it? Has your primary care doctor or a preventative specialist described a recovery that sounds impossible given your life? Has the bunion gotten worse over the past year or two? If you're nodding at more than one of these, you're probably past the point where conservative care management is going to get you where you want to be. And you probably have been making that calculation based on a version of surgery that no longer applies. The right evaluation starts with the right diagnosis, understanding the underlying structural causes of the bunion, not just what it looks like on the surface. And it ends with a treatment plan that's specific for your anatomy and your goals, not one size approach borrowed from a textbook. Knowing you might be a candidate is step one. Knowing how to evaluate the surgeon you're talking to is step two. There's a version of this conversation that most patients have never had. They sit across from a surgeon. The surgeon describes the procedure, outlines the recovery. The patient asks how long before they can walk and go back to work. The surgeon says 6 to 8 weeks, maybe 12. The patient nods, processes that, and either schedules it or decides to wait. What almost no one asks is, why 6 to 8 weeks? What in your technique requires that? Most surgeons performing bunion surgery today have 1 or 2 procedures in their toolkit. They were trained a certain way. They operate a certain way. The recovery protocols they used were built around those techniques. When a surgeon tells you the recovery will take 2 to 3 months, they're describing what their technique requires, not what bunion surgery inherently requires. Those are 2 very different things. In my practice, I know 5 or 10 approaches to most conditions I treat. The choices of techniques depend on what the diagnosis actually calls for. the root cause of the bunion, the specific structural issue driving it, what the bones and soft tissues look like, what the patient's goals are. Patient-specific surgery means the plan is designed around the person, not what the surgeon happens to do most often. Stop accepting the recovery timeline as a fixed fact of bunion surgery. It isn't. It's a fact about the way a particular surgeon operates. Start asking about techniques. Ask whether the approach being recommended allows for immediate or same-day weight bearing. Ask whether the surgeon uses minimal invasive methods for this procedure. Ask what the expected incision looks like and why, and whether the recovery model involves early range of motion. A surgeon who can't answer those questions clearly, or who describes a recovery that sounds like 1995, is giving you one data point that you didn't have before. You don't have to figure all this out in a single appointment. There's a simple thing you can do tonight to get you started. Most people who've been living through bunions have been living with the wrong questions. The questions they've been asking, is it bad enough to do something about? The question they should be asking is, what is modern treatment for this? And am I getting it? Those are two very different questions, and they lead to two very different places. A patient who goes to a surgeon using 30-year-old techniques and a patient that goes to a surgeon using minimal invasive, patient-specific techniques are not having the same surgery. They're having procedures that share the same name and differ in almost everything else. The incision, the recovery, the timeline, the likelihood that that problem comes back. The name bunion surgery obscures it entirely. It makes people think they're comparing the same thing when they're not. The patients I see who wait the longest aren't the people who made a careful, informed decision to manage conservatively. Most of them are people who made a decision based on what they were told years ago and never revisited it with updated information. That's not a failure of will. It's a failure of information. And that's fixable right now. Here's what to do tonight. Write down your current symptoms, how long you've had them, what activities they affect, how you're managing day to day. Not for anyone else, for you. So you have a baseline when you talk to a surgeon. Look up whether the surgeon you're considering is one you've already seen performs minimal invasive bunion surgery. Write down the recovery timelines you've been given or that you've assumed and hold it next to the question. Did the surgeon explain why their techniques required that timeline? If the answer is no, that's a gap worth filling. If you've been told surgery isn't worth it by primary care doctors or general practitioners, understand that this is outside of their area of training. The right person to evaluate your bunion surgery options is a podiatric surgeon who performs this procedure regularly and can speak specifically to what their approach looks like. The version of bunion surgery that most people are afraid of is real. It just isn't the only version, and it isn't the modern version. Every month spent adjusting shoes and managing the pain is a month you don't have to spend that way. Getting the right information changes what's possible. And if you want to understand more about how to find the right specialist for the foot and ankle problems, watch this next. We did a full breakdown of the difference between podiatric surgeons and orthopedic surgeons for foot and ankle care, the training, the focus, the outcomes, and it's the clearest explanation of why the specialist you choose matters as much as the procedure yourself. I'll see you there.